Welcome to the OT Potential Podcast. Before we begin, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. After listening, you can log into the club to take a 5-question quiz, and we will generate a certificate for your time today. Okay, here we go.
Hello, everyone, and welcome to the OT Potential Podcast. I'll be your host and moderator for today's discussion. My name is Alan Linick. I'm excited to see you all here. Today's topic is going to be OT and prevention, something that's been coming up on the OT Potential Podcast with some frequency lately. So we just thought, let's just do it. Let's just make a whole one about this thing. And to do that, we have two wonderful guests joining us who are going to help guide us through this discussion. First off is Alyson Stover. Alyson is an occupational therapist and has obtained her Juris Doctorate in law with a postgraduate certificate in health law. She and her husband own a private outpatient pediatric practice, say that 10 times fast, in rural county in Pennsylvania. Alyson is also the current president of the American OT Association. Alyson, hello.
Hello.
How are you?
I'm great. How are you?
I'm great. I mean, I've already gotten my one tongue twister flub out of the way, so I feel really confident about the rest of this.
Well, that's almost a treatment session when you come in to say that pediatric private practice 10 times. It's one of
Oh yeah.
You've already been treated.
Back pocket that. I feel better knowing that that's a test. Welcome. We're excited to talk to you. We've also got Sarah Lyon. Sarah Lyon, OTRL, is the CEO of OT Potential and is on a mission to bridge the gap between research and real occupational therapy practice. Sarah, how you doing?
I am so great. Alyson and I have like 10 hours of content for this 1 hour webinar. So I can't wait to see if we can pull it off, fitting it all in here.
We're going to cram as much of that as we can into here. But before we do, Sarah, I need you to say pediatric private practice 5 times fast.
Pediatric private practice.
That was 1 time slow. All right, we're going to move on. We do have so much to cover, and we've talked about a lot just in other OT Potential webinars and podcast episodes recently about this idea of shifting to value-based care and prevention, like incorporating prevention into OT practices and the effectiveness, right? The phrase, I wrote it down this time so I wouldn't mess it up, the idea that an ounce of prevention is worth a pound of cure, right? And like how true that can be. And it's been coming up in relation to a lot of our talks recently. We talked about it a bit with Chris last episode in terms of chronic stroke. We've talked about it in terms of prenatal care. It's just something that keeps coming up. So today we're going to walk through this idea of OT and prevention and honestly, why we haven't already shifted in a bigger way towards prevention when we know that it will be more cost effective and more clinically effective. And it kind of stinks, I think, to have to couch a lot of things in this field in cost. But I mean, I'm sure you both are well aware, as is anyone, that there's nothing more like financially disruptive than being ill in the United States, right? Like it's just a sad reality that we live in. So I guess to kick this off, I'm going to pose a question to both of you, starting with Alyson maybe. Why does this shift towards prevention? We understand that it's like impactful and effective. Why does it feel urgent right now?
Yeah, this is a great question. And so I think there's a number of things that contribute to its urgency. There's 2 that really speak out, I think, very loudly. One is just with the rapid development of health tech and digital health tech, this is going to be something that either those of us trained in the delivery of healthcare services can get involved in, embrace, and rapidly ensure that it's being delivered in a way that does truly help us feel like we are accessing an ounce of prevention. Or we can continue to have this as something that we can't figure out yet, put it on the sidelines, and allow a very commercialized industry to take over that without the clinical knowledge and expertise adding to that product development. So prevention is happening, particularly through this rapid digital transformation of how we experience health. We need to be a part of it or not, but that's going to define what prevention really is and if it's effective.
Yeah. And I would add, well, one, for me, just this personal journey of thinking about value-based care. And historically, in our fee-for-service model, we have just been waiting until people get sick to see OT. And we see these super high complexity patients after cancer, after Parkinson's, after a car accident. And in a way, I don't want to say fee for service kind of pushes us that way, but that has just been the natural course of things. And as we head into payment models are more value-based, that's what's going to be pushing insurance companies, providers to be thinking of intervening earlier. Like Alyson said, in either leveraging health tech or leveraging other providers. And I see OT as such a great match for that, but it really is a mindset shift. And that's why I wanted to do this episode specifically, because like, just as I've been talking to people, it raises questions of, can we do that? Is prevention the same as wellness? What would I do if I got a low complexity patient? So I really just wanted to walk through what it would look like in a really practical way today, because I think we are positioned for it. And I think the time is now. And if we miss this window of opportunity, I don't know what will happen. Or we can't miss it. We can't miss this window of opportunity.
Is there a, because I think this conversation about prevention seems so inherently tied to the idea of value-based care, because it, I mean, logically there's a sort of obviousness, right? That like, yeah, if we're treating based on long-term value, then preventing things is like, that's a winning strategy, right? But is there something deeper there in terms of like how we get to like this sort of ideal value-based care system by incorporating prevention? Is there a way to achieve a sound value-based care process or platform without prevention?
I think no. And I think this is a really good point, right? Because when we move to value-based care, one of the biggest discussions that we have are, what are the most appropriate outcomes, right? So how do we know that you've provided care that equates to value, right? And if we do not incorporate prevention into that, and what prevention then looks like or results in for the individual and the population, what we're going to do is we're going to create outcomes that either can't be achieved or are incorrect and are guiding us completely the wrong way. Look, prevention is what'll get us to a place where the outcomes of less missed days at work, less missed school days, greater participation in community opportunities that increase spending so that we are enhancing, economic wellness, right? All of that, those are great outcomes that, yes, I do believe that we can achieve, but not with the current state of comorbidities that our patients are coming to us with. And so I think value-based care tells us we either have to embrace prevention and walk along the path of bringing prevention at every phase so that we can start to shift the entire community to a better wellness start, or we have to say that we want to give up on those great outcomes like more participation or less missed days at work, because we're not going to be able to achieve those with the current state of health and wellness that our clients have.
I guess I want to ask, we're gonna dive into like how to gear this conversation towards providers later, but I feel like it can be a weird sell, right? Like I want to pick your brains on this for a second before we show this very cool prevention pyramid that you have been working on. But I think there's this thing that sort of naturally happens, and the example I can think of is specifically geared towards mental health, because I know a lot of people who are taking medications for like depression or anxiety or other things, to use a non-medical term, things that they're dealing with, and there's this thing that I feel like sort of happens where like the medication is super effective, and then after a while of taking it, they're like, well, why am I even taking this? Nothing's wrong with me anymore. And then they stop taking it, and then it becomes really clear what the preventative aspect of the medication is like helping with. So is there, how does that, how do you get around that idea of like, yeah, if prevention is actually working, it can be really hard to quantify what it's doing, right? Like what's the difference between the outcomes we're seeing when we really take prevention seriously and when we're not? Because we're either doing it or we're not, right? So how do you approach discussions like that, where it can be really hard to like tangibly look at what prevention is doing when we're doing it versus when we're not doing it? Or is there like a way to broach that?
Yeah, I think you're getting at one of the barriers of why we do see people late. And it's this idea of motivation, that therapy is hard lots of times. And there can be this idea that people are only motivated to go to therapy after something bad has happened. And that is a conversation that I've had multiple times as we've been talking about prevention. I don't know if that's a true narrative. I just don't know if we've fully given prevention and education around it a real try in healthcare. Like, we don't provide the education. We don't, either at the primary care level or even lots of times in therapy. I've been thinking specifically of like just the area of sleep. And if you sleep well, the number of protective factors that introduces into your life is astounding. Like, but we do not spend our time at our medical visits talking about that because our reimbursement models haven't set us up for that. So I think in the right way, there's a way to present prevention in a way that is really motivating. And I don't fully buy the narrative that patients won't be motivated by it. But you're touching on a true narrative there that people have in their minds.
And, I think that we have data that really supports what Sarah's saying, that that's not the narrative, right? One of the most incredible factors in prevention medicine is understanding a diet that can really support health and wellness, right? So we'll talk a little bit when we dive into our case study, but something that I learned as I was exploring this is that if you do live in an area where there's a lot of nitrates in your water, simply increasing the amount of vitamin C in your diet, even if you don't have the ability to change anything else, just increasing the amount of vitamin C can reduce the consequences of having those high nitrates. And so when I think about prevention and I think about sleep and I think about diet, right, these are actually two commercial industries that we know are multi-billion-dollar industries, right? People actually are pursuing the very interventions that are part of a prevention model. It's when we don't marry those to the very real science of medicine, that's where you just have a lot of people trying a lot of things, right? But see, integrating it into the healthcare system is the opportunity to marry the changes that we actually see people are motivated to do. Even when they fail again and again, we're seeing them motivated through multi-billion-dollar industries but they're not married to medicine. And so it's not making them necessarily feel better or sustainable for the course of their life. And so I think the narrative is, yeah, I want to know the simple changes I can make to feel better, to be better. But my doctor and my healthcare practitioners, they're not telling me what that is.
Mm-hmm. I do want to let's because like we said, we have so much more like things to talk about that we have time to talk about it in. But we have this really interesting and super informative visual graphic that you guys have put together for the occupational therapy prevention pyramid, just to kind of demonstrate what OT and prevention can look like. Can you two walk us through what's going on in this image?
Yeah, when I first started just conceptually thinking about OT and prevention, I was having my own troubles of like, where does wellness come in? As OTs, we need that diagnosis usually to see someone. And this pyramid just made everything click for me finally. This is a common prevention pyramid that's used in public health. It's used in like recovery medicine a lot, something that lots of fellow providers are familiar with. And it breaks prevention down into primary, which is at the general population level, that is at the bottom of the pyramid, where you're helping prevent disease and promote health just with its general population. And secondary there is a diagnosis, usually a precursor diagnosis like disrupted sleep, biomarkers out of range, something that gets noted usually at the primary care visit. But honestly, lots of times there's a wait and see approach or a medication approach. There's very rarely, I would say, therapy at that time. Tertiary is when we tend to see patients. This is when there's a more progressed diagnosis, cancer, carpal tunnel, pelvic floor therapy. And then we come in, and our role in prevention is to prevent complications and prevent going up to this quaternary, which is unnecessary medical interventions. So this just made it all click for me, where we're usually at this tertiary level in OT, and could we be doing more at this secondary level with those low complexity patients where they do have a diagnosis, they have a reason for referral, but it's not as advanced as what we're usually seeing.
Yeah, it's cool. It feels like sort of, we touched on this case study with nitrates in the water. It feels like that's sort of what you're aiming at with this secondary tier, right? It's like you've identified an at-risk demographic, and it's like, great, how can we start doing something proactive before we hit the point where there's damage being done that leads to some kind of chronic or acute condition, right? So if we're looking at this tertiary block, you mentioned that this is sort of where you feel like most OTs kind of like live, is in this area of treating people who maybe already have a diagnosis or are already dealing with chronic issues of some kind. What could OT that is focused on tertiary prevention look like?
Yeah, I wanted to start there because that is where we live the most, is in this tertiary level. But even there, I'm thinking of like a hip replacement. That was something that I saw all the time in the hospital. Even with a hip replacement in that tertiary level, so often we are also simultaneously doing secondary prevention. We're trying to prevent a fall. We're trying to prevent rehospitalization, that quaternary. Like we are kind of moving between all three levels simultaneously. And until I had this model, I never realized that I was doing that. And so this was really helpful for me to see, like, we are already operating at these different levels. And for me, I just hadn't been using these words before.
Yeah, I would agree. And I think, like, in the world of pediatrics, this suddenly made my sessions make more sense, right? Because a lot of times we're doing an intervention for, a developmental delay. And it might be a really significant delay. Child is not yet walking, or a child, isn't using their hands in a meaningful way, or they can't, feed themselves and that type of thing. And where I've always seen this to be this tertiary space, now having this language, they have this diagnosis, right? Like developmental delay. They are showing that they are unable to achieve things that they have to achieve. But why are we progressing their development anyways? I mean, the whole reason we're progressing their development is so that we prevent their inability to participate in things that are going to occur later in their life. I need you to know how to form certain grasps and have a certain level of strength in your hands so that when you go to kindergarten, you can go to the bathroom by yourself, right? So I'm actually working on, yes, progressing your development, but I'm doing that also with the mindset of it's really to prevent your inability to do things that you're going to need to do later. I'm trying to prevent your inability to learn in your school environment by getting you to a space where you can organize your body when you're 3 and 4 instead of 12.
Wow. Yeah. I mean, so we mentioned you're kind of leading into this next question, which is then if we're focusing on this secondary prevention layer, I mean, that's sort of like for a lot of OTs, it sounds like, based on what Sarah says, like we're living primarily in this tertiary level, a lot of us in this field, right? So moving down, trying to aim downward on this pyramid, what does trying to push that focus into secondary look like on a grander or more general scheme?
Yeah, so I love this question because, like I said, and like Sarah was just saying, I think we're already doing so much of that secondary prevention type of work when we are also doing tertiary. This pyramid is also the first place that made me realize that we're not living in just one of the spaces, right? Like I always had this view of prevention as something that you were doing primary prevention or you were doing secondary prevention, and not really seeing that we actually have this beautiful flow that's occurring throughout our entire session when we're working with an individual. And that's because the nature of OT brings us there, right? I say my mom just recently had a knee replacement. And I think that the work that she did with the physical therapist and the physical therapy assistant was profound. It was life-changing and she needed it. But when she gets her second knee replacement, she's not going to be able to bottle up that strength and just like press a button and reactivate that strength again, right? But what she learned with the occupational therapist and the occupational therapy assistant in better body mechanics for dressing and energy conservation techniques are not only something that she can almost like push the button and do again when she has her next knee replacement, but actually she can be doing even prior to that knee replacement. We are always living in that space of routine development, habit formation. And that in and of itself is a way of prevention. It's changing a habit or a routine to be embracive or to embrace. I like to make up words sometimes, embracive.
I like embracive. I think that, Alyson, if you think about it, every word is made up.
That's true. This is true. Yes. So, we should embrace this idea that every action that we're doing is actually in an effect trying to change maybe a habit, a routine of how they were doing something or couldn't do something before. And so I think what we really want to think about is not so much how do we do it, but how do we document it? I think to push down into that secondary space, we need to think about language where we're talking about how we're intervening for the now, but what it can also be preventing in the future.
I had such an interesting experience when I was practicing at my small hospital. I did this in-service for our doctors that was 15 minutes, and I showed them like 5 slides of things I could help with. And they just sent me a lot of patients. Like as soon as they saw something that reminded them of those slides, they would send me patients. And they were sending me low complexity patients that had like easier problems that I would say are in the secondary, like someone's sleep had just gotten off. I never got like hypertension but I can imagine getting, as soon as a biomarker gets off, making that OT referral, knowing that lifestyle interventions are like the forefront intervention for those too. And what was interesting for me is a lot of those patients were an eval and one treatment, and then I was done. And that was so strange for me in OT because I was so used to stroke patients that I saw for 12 sessions. And it was such a mindset shift. But I also remember being very happy in my job because I had this variety in my caseload. I was seeing these low complexity patients where I was like, yes, I can help. Let's do this in an eval in one treatment session and you're done, alongside my higher complexity patients. I was also thinking, as we were talking about our past episode with Carlin Rayom, who does more pelvic floor therapy and sees moms after birth. And she mentioned that a lot of her patients are actually low complexity, and it's an eval or 1 or 2 sessions, and they get what they need and they're done. And that is just a shift for us to be thinking about. Seeing people earlier means they won't need as much intervention, and it honestly feels weird, but it's awesome. And I want us to like shift to thinking of that as a good thing, to have that kind of variety on our caseload.
Yeah. You mentioned that there's a mind shift. Holy moly. All right. You all tricked me.
I'll give you my card afterwards.
Thank you. Yeah. I need help. Mindset shift. Oh, wow. Okay. You talked about how you have to change your mind about how, it feels weird or feels different, right? Is there an approach change as well that you incorporate into, doing sessions with a low complexity patient that walking into the room, like, okay, I'm probably going to see this person today and one more time, and then not again. Is there an approach difference there that you incorporate into prevention work that is different from the way you interact with a patient that you're expecting to see over the course of months, maybe even years of therapy?
I do think that there's a little bit of an approach change, but the approach change is coming from every time we enter a room, and particularly this is something that we say in my clinic all the time, is every time you enter in, do something that, if that's the only time they came to see you, would have a meaningful effect on them, right? But see, the problem is that I don't know what that is most of the time, because I'm seeing children who are at such complex stages and even advanced risk factor engagement that what is that one thing? And so I think the approach is shift that needs to happen. Is going to sound strange also, but we don't have to think as hard, right? Like those simpler, small movement changes, that education, that handout that you're giving to patients when it's really, they don't need just that handout, but they need the full on direct intervention. And they can do that handout, after they're better from rehab. Like, it's shifting the idea to recognizing and saying, oh my goodness, if I saw my patient all the way through from like when I wanted to when I felt comfortable discharging them, what would I discharge them with? It's about treating them at that perfect discharge session instead of thinking about it as an evaluation session.
It seems like, I guess to sort of like piggyback off of that question into another thought, is it seems like a lot of these, when we're gearing towards prevention and towards lower complexity, like as we slide backwards on this Well, backwards maybe isn't the right term, but as we slide over on this like spectrum of care, it seems like it incorporates a lot more discussion in terms of general lifestyle changes, right? We're changing our sleeping habits, we're changing our exercise routine, we're changing our dietary habits. And I think these are traditionally, those three things in particular are like, these are the things that everybody knows, right? In the back of everyone's mind, they know, yeah, if I eat healthier, sleep better, am more physically active, generally speaking, I will live a longer life with like, and the years of that life I live will be in better health, right? How do we, how do we bridge that gap between like, I'm aware, to actually effectively changing people's habits? Because that's the hardest part. Like I know, like I'm like, yeah, if I lie in bed, if I get into bed at 9:00 and then I scroll on my phone until 11:30 every night, which I do, like that's going to negatively impact my sleeping habits, right? And I know that, but like, how do we go from educating to like really helping someone make the change that's going to give them the prevention in the long term in the way we're looking for?
I think so often as OTs, we live in this world of simple but not easy, where a lot of the changes that we talk about with patients are simple, but they are not easy to make. And it really takes, I was thinking as you were talking, something else that's different about this approach is I think there needs to be such a close coordination with the primary care provider where they kind of tee the patient up to be like, hey, I want to talk, or I'm hearing that sleep's a problem. There are things we can do. I'm going to send you to an OT, even though the primary care doctor probably could talk about those things in the office themselves. It just a lot of times makes more sense to pass that off to an OT. I was thinking about how I mentioned earlier when our primary care providers would just send me lots of patients. And a lot of times it would be like to talk about driving safety, where they knew it was clear that the patient was close to needing to give up the keys, but they would send the patient to me for that eval just because I would get that full hour with the patient to really walk through driving safety and where the patient was at. And usually by the end, they would be ready to give up the keys. It just took that extra time and that extra discussion. But that was a pretty close coordination with the primary care provider where they sent me there for such a specific purpose and kind of teed the patient up for that.
I love that. I love that example specifically because I think it's so clear. No, like, having that discussion is so hard, but showing someone tangibly like, hey, these are reasons based on the hour we just spent. These are reasons why it might be time for your safety and others to hand these keys over, right? And I like that you mentioned incorporating the providers here as well, healthcare providers, because I think that leads us nicely into the next area of this conversation, which is like, how do we talk to providers about seeing patients earlier at that level of secondary prevention that we're sort of like striving towards pushing into?
Mitchell's sharing a link in the comments, which is my beginnings of like a handout to share with primary care providers. I don't have it quite polished up. I would honestly love if anyone wants to read through it and make comments. But one of my hypotheses based on my own success, and I've heard this be successful for other OTs, is just being really clear about those treatment areas, the sleep, movement, eating habits, and getting those in the provider's mind, like that as soon as they see problems with that OT is the referral that they can make, even in the low complexity stage. And if there's, again, like biomarkers off, something like hypertension, and they think that lifestyle should be part of the interventions, to have confidence that they can send those people to OT. So I have this handout that just has our main treatment areas. And then on the back is our prevention pyramid and kind of like, please send please send people to OT earlier. And I want to make it editable so people could put in their own information into this handout. This is something I will polish up and put in the club for people to utilize. I'm curious for you, Alyson, though, what that looks like in pediatrics. Like, I can so clearly wrap my mind around that for adults, but I don't fully have my mind wrapped around it for pediatrics.
Yeah, so I think that there's two things when I think about it from a pediatric or really like across the lifespan phase. One is that I actually think that it's not a hard conversation to have because, right, these are simple but hard. Simple but not easy, right? Changes to make. And so actually a lot of physicians are looking for someone who's willing to take the extra time with that patient because they're burning out from this maintenance and oversight of every single element, right? So to give you the assessment of your blood work back and prioritize what are those things that we need to triage as you absolutely have to do and make sure you're getting your medication and all of those pieces. And then to have that time to also have the conversation about sleep or about diet in a way that's can evoke change in the patient. It's I think they're looking for somebody. And so I think that, one is, yes, utilizing a handout similar to Sarah's and just really sharing the, this idea of like, here's where I can do a very simple sort of assessment and intervention with your client that's going to save you time and hopefully have a better outcome for them. Right. I think the other side of it, and it's something that I actually, if anyone was at the AOTA annual conference in Philly last month, was what I gave my farewell presidential address on. And it's that we have to stop with our complex language. Just say, like, I think that the pediatricians that I've worked with, some of the things that have been really effective is when I say things like, I do feeding. Right? I don't go into the aspect of I do the sensory component and bolus management and food aversion aspects of it. I say, like, look, do you have a kid that's got trouble feeding? Like, go ahead, send them to me. I do feeding, right? And I think it's getting comfortable with not over explaining ourselves, right? Looking at those big overarching issues that these healthcare providers are seeing in so many of their clients and have no idea what to do with, and saying, like, I do that. Just that. You don't have to explain what you're doing entails unless they're going to ask more, in which it's great to share the information. But when you're just approaching them saying, like, look, I can do that and I can make your patients have a better experience and take that burden from you, I think we're going to find that providers are really, they're going to be eager to take us on.
Is there, I want to touch on this really quickly before we move on, because I want to make sure we have time to really dive into the case study and also into some of the questions and comments I'm seeing coming through from our live watchers and listeners. But I feel like it's interesting and important from where I'm standing anyway, especially with Alyson here, who's like running a practice, and especially with your background in health law, to get any comment you might have about how insurance can play into prevention, because I see you nodding, but I know we could probably do a whole episode just about that. But just any quick thoughts you have about incorporate, like, just the way insurance plays into this. We mentioned earlier, that cost is like one of the biggest barriers to getting the care that people need, right? And so going into value-based care, it feels like incorporating insurance or like talking about insurance is important to that discussion. Do you have any thoughts or comments about how insurance and coverage and all that sort of bureaucratic, I guess, aspect plays into prevention, and especially at the secondary prevention level, where we're looking at patients that you might have to justify, or patients who might have to justify to their own insurance companies why they're seeking treatment where they're at, and getting help financially on those fronts?
Yeah, it's a great question. And in very real practicality, this is actually going to be a shift that insurance companies love, Right now, we're seeing a continuous lack of denials, appeals, things not being considered medically necessary. And you know why? Because they're moderate to high complexity. Because they are, when you look at what insurance companies are looking at, they're not measuring the number of clients that they're paying out towards. What they're doing is they're measuring how expensive each individual client is. So if they suddenly see a clinic that has an increase in the number of low complexity evaluations that they're doing, or low complexity plus 1 to 2 sessions, that's not going to red flag them. You're not going to, those aren't the patients that they're trying to deny. The patients that they're trying to deny are the ones that have those moderate or high complexity because they're expensive, right? So you don't even really need to explain it to insurance companies in the beginning, because what they're going to see is they're not taking into account more of our consumers are being seen. They're taking into account, hey, look, the people being seen at Alyson's clinic, oh my goodness, it's the only clinic we see in pediatrics that is seeing people for a low complexity eval and then only 2 visits, right? It's actually going to take them off guard, and they're going to love the idea of low complexity in reimbursement structure.
And you've seen that. I mean, that's why I directed this question at you. So you've seen that firsthand, right? Like in
yes.
Yeah.
Yeah. So the thing that the conversation that we have again and again, right, is the idea that when we are arguing or having these appeal fights, it is for our clients that, have been on with us for a long time or have very complex or high number of comorbidities. We're finding that when we submit a low complexity evaluation, it's not that's not the denial coming back. And those aren't the records they're asking for, right? So even in the, hey, we want to do a utilization review of your patient, these aren't the patients they're targeting for that. So it's almost like it's not even a conversation that has to happen. They're approving them, they're paying for them, and they're not red flagging them as utilization review clients.
Wow. Logic from
Found
insurance.
Yeah.
I have so many more questions about that, just because that's something that is of deep interest to me as someone who interacts with the healthcare industry, mostly as a patient, like as a consumer of services. But we don't have time. So we're going to move on. I want to break down as best we can this case study for early OT referral that we're looking at. We talked earlier about, as an example, populations that can see a high concentration of nitrate pollution or leaching into their water supply, especially well water. So I wanted to break down this case study from rural Nebraska, if we could. And then we'll move from that into our Q&A. And I see a couple already in the chat, so I'll make sure I hit as many of those as I can.
Yeah, I just wanted to share this story from it's very specific to my area. I like this story because it feels outside of what OT would normally do. I think a lot of the things we've talked about so far feel so in our wheelhouse, like send patients earlier for sleep, send patients earlier for feeding. I also think as we look towards prevention, there are new opportunities that have this degree of impact that to me is so emotional and so beyond what I ever thought I would get to do as an OT. So to tee this up, I live in central Nebraska. We have some of the highest rates of cancer in the United States, specifically pediatric cancer and specifically pediatric cancer deaths, because we have children getting such aggressive cancers. And that is strongly associated county by county with the level of nitrates in our water. That is just a byproduct of farming. We have more and more established science behind it. The state of Nebraska is really taking this seriously. Literally just 2 days ago, our governor put out another statement on it. But this So we know we have this problem. The solution is pretty simple. It's to screen your water. And then there's programs where they'll actually pay for a reverse osmosis system. Like, that's how serious we know this is. But the medical community honestly hasn't really gotten behind this movement. I think there's just a lack of education there. And I started to ask the question, like, what if OTs could be part of this ADL safety issue and be talking to our clients? Is this another thing where if a doctor was concerned, they could send them to that OT for, like we were talking about earlier, just like that hour discussion to walk through what that would look like? So I made this graphic that walks through what an early OT referral would look like and without early OT. And if you have these ongoing high nitrates in your water, that puts you at risk for minor health ailments, Alzheimer's disease, Parkinson's disease, diabetes, multiple kinds of cancers. For the mom and baby, it puts you at higher risk for spontaneous abortion, spontaneous preterm labor, blue baby syndrome, CNS malformation, and also those pediatric cancers. So that list of the things is what we usually see patients for, but thinking towards prevention, we truly have the opportunity to prevent these things from happening by talking about drinking safety and water safety into our treatment sessions. And I can't emphasize enough how, like, thinking of this prevention, and I've been talking to different groups and everyone is like, yes, we really need OT here. It's never been so easy to engage with everything from like our local university to our central Nebraska health district to just like motivated groups. We have multiple foundations working on this, and it's almost like they were all looking for a profession like OT where we could go in at that individual level and help educate. That's what's missing. Public health is involved. There's all these other foundations, but that person in the medical doctor's office that could really spend the time to provide education. And it sounds like I might be helping with a pilot study in our local area geared at this.
Yeah, I mean, that graphic, it's, how do you say no to that? Like, it's only benefits, right? I mean, I don't know. Is there anything you'd like to add to that, Alyson?
Yeah, I think one of the main
or Sarah,
Alyson up one of let me thank you to tee Alyson up. One of the main questions I get is, what exactly would that look like for an OT that feels a little different than what we usually do? Could we bill for that? And that's where Alyson put together this incredible 33-page document about what that could precisely look like and helped answer that question for people.
Yeah. And, I think one of my other thoughts about it is really the idea too, that again, this isn't going to look different than what we're already doing, right? But it's actually giving the providers a clear way to know there is somebody that can help with this. One of the major interventions, if you will, that we do at our clinic is we get individuals, children who would be Medicaid eligible, signed up for Medicaid as an intervention, right? Because the thing is, in occupational therapy, health maintenance, navigating your healthcare system, these are all written out in our practice framework, right? These have evidence behind the interventions, and that these interventions have a unique place in the scope of occupational therapy. So we are the right people to be saying, wait a minute, is there something going on in my community? And how do I just integrate that in to the work that I'm already doing? And so when you walk through this document, a lot of it is about, here's just some additional red flags that you can give to a provider. And here would be the referral and why they would be referring them to you. And then oh, here's some things that you might add to your evaluation that you're already going to do, right? So here's a checklist about nitrates in the water. Or here it just happens to be the past medical history that's most common for individuals coming from families that do have high nitrates in the water. Oh, by the way, we know that the somatic physical symptoms that children are experiencing during this, that these can also be highly linked, right? And so again, can I add that one questionnaire that is targeted towards this information or this risk factor? Because at the end of the day, right, again, insurance, they're not asking us necessarily what's in your evaluation. They're asking us from that evaluation, what is our assessment of that person telling us? And it's great to be able to put that assessment in there and say, hey, you know what? My assessment is saying that this child is at greater risk for X, Y, and Z because they live in an area, in a home that has a well water that they haven't tested in over a year. And I provided information about that to the caregivers and connected them with the very public health initiative happening that is going to test their well water for them, right? They're going to be, the outcome is so profound, and you're not changing your billing codes. When I'm doing an evaluation, whether I'm asking about your well water or I'm asking about how many steps to get into your house, I'm asking about your home environment. And so I wrote that to just show where you can even integrate the education in a client you're already seeing, and that you're probably already seeing because some of these nitrate risk factors have progressed into an actual diagnosis. And I've included the codes that you would use and the rationale for and justification for using those codes.
I hate to step in and move us along there, but the document is going to be made available on the OT Potential website. I encourage everyone to check it out. And I do want to get to some of our lightning round audience questions here, listener questions. So we'll kind of sprint towards these as we approach the end of the OT and Prevention podcast episode here. First question here is from Vera Gallagher, and this relates back to something you were talking about at the top of our episode today, Alyson. How are you defining health technology? You mentioned that health technology is developing. And in a related way, how is value-based care measurable?
So that's great questions. And I define health technology the way that the consumer industry is defining it, because at the end of the day, that's who I treat, consumers. And so while there are probably plenty of different ways and spaces that I might choose to define it, I actually go to a source. They're called CAE. They put on the CES conference annually for tech. And I look at how they're defining tech, because they are the consumer tech space. And so how they're defining it is how our world is going to define it. And that is things like wearables and understanding things like GPS monitoring. So that's how I'm defining it. And when I think about value-based care, this is something that look, value-based care was introduced in the 90s with the Balanced Budget Act. That's when everybody thought we were really going to move there. They've been talking about how to measure it. And we actually possess really great outcomes that aren't being looked at. Right now, value-based care by some of the proposed models is being determined by how many opioid prescriptions a client has in a 100-day episode. What's the average length of stay for a certain diagnosis, right? What do I think value-based care looks like? I think value-based care looks like, increase a number of protective factors. I think it looks like more days at work, or less missed days of work, or less missed days of school. I think it looks like, some of those outcomes related to participation and prevention is how we can get insurance companies there for doing that instead of opioid prescriptions.
Our next question is from Meg McLaughlin. It says, Would it be interesting to apply what we do in early intervention with children under 3 to other ages through through adulthood, progressing skills to prevent disability later on? I guess that's more of a comment than a question. But Sarah and Alyson, do you have any response to that?
I mean, again, I think this is what we do in our OT sessions, right? Like that's what we're doing. Because for us, advancing skill is not necessarily changing the person in any capacity. It might be changing the way you perform the activity, or it might be changing the environment that you do it in. So I think that I love this statement. And I think we are already doing this. Let's find ways to document it and then share it so that people understand what that value really looks like.
And in just a few words, because we are approaching the end here, we have a question from Meryl Gilbert. Thinking about how everything we've talked about can be applied to maternal mental health and well-being, do you think it will be feasible?
Absolutely. I noted on the document that Alyson sent out that she called out the referral to OT early in the maternal journey. And I wish that that was something that was happening all the time. We just put out a new clinical decision support for postpartum anxiety in the OT Potential Club. And so many of the interventions on that are things that we've talked about today, the diet, exercise, sleep, things that are so in our wheelhouse. And ideally, we are seeing moms early. I would love an OT referral for every new mom. I think there's so much possibility here. And the impact is so profound. I keep thinking like low complexity actually means high impact. It means that you are seeing someone early enough where you can really change their trajectory. When we see people so late in their process, we can always impact their quality of life, but it's hard to change a trajectory when we see someone so late. When we see people early, you can really change a life. And I think that's really profound when you think about mom and baby.
Alyson, we're about to end here, but in, let's say, 2 sentences or less, what would you say is the most important single takeaway from this conversation that you would want to end us on?
Yeah, I think the single most important takeaway is self-reflection in your practice. Look at these documents that you have available for you and how can you do it tomorrow? Maybe it's something as simple as, you know what, I'm going to start to use some of this secondary prevention language in my documentation. Maybe it's, I'm going to take that document that Sarah shared and I'm going to try to let my PCP know that I can see older adults who need to have the driver conversation. Maybe it's having the courage to just bill a low complexity evaluation and see what happens. I think the takeaway is recognizing that doing some self-reflection in this space will help you to see you're already doing this. And we can actually really change the trajectory of health and wellness in the entire country if each of us just took one of these things and did it tomorrow in practice.
Thank you so much. Alyson Stover, Sarah Lyon, thank you so much for joining us for this talk on OT and prevention. There will be a link to the post-course quiz that will be posted as part of this episode and also in our live chat. Make sure you check that out so you can get your CEU credit for this episode of the OT Potential podcast. And with that said, thank you both again for joining us for this discussion. We're going to do our very well choreographed farewell salute that we've been working on this whole time. So okay. Thank you again and goodbye.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.